would have preferred he was here, but he's not, so he will address why in his talk. It's Kevin Wilk from the States. He works since many years in Birmingham, Alabama. It's really one of those guys that really sees athletes, pro athletes, and from the post-op to the return to play phase. So you will hear his talk, and then I hope that he will be really online. It's 6 in the morning. We'll be back home, but he promised us to be online for Q&A. So, please. So I'm happy to present the next speaker. So I would have preferred he was here, but he's not. So he will address why in his talk. It's Kevin Wilk from the States. He works since many years in Birmingham, Alabama. It's really one of those guys that really sees athletes, pro athletes, and from the post-op to the return to play phase. So you will hear his talk, and then I hope that he will be really online. It's 6 in the morning. We'll be back home, but he promised us to be online for Q&A. So, please.
Hello, my name is Kevin Wilk, and I'll be speaking to you about advanced shoulder rehabilitation, exercises, and return to play. My apologies for not being able to attend this wonderful meeting in Switzerland, in Bern, Switzerland. I had some passport issues in my renewal. Unfortunately, the passport was lost along the way or with the department, and I had to reapply, and it's still in the reapplication process. So unfortunately, I'm not with you there. My talk is going to deal with overhead athletes, which here in the United States means a lot of baseball, softball, but certainly around the world, it certainly means tennis. And certainly this tennis player to your left is one of the all-time best, if not the all-time best, in my opinion. Tennis player, Roger Federer, who's obviously a Swiss player, but certainly volleyball, golf, all those things involve the shoulder, which I plan on discussing to some degree. These are my faculty disclosures, none of which will specifically interfere with this presentation or will hinder it in any way. As I mentioned, I apologize for not being at the Swiss Physio Conference. It's a wonderful conference. I've been there before. My good friend Mario Bazzini, Dr. Bazzini, been very kind to invite me a couple times, and I visited beautiful Bern, Switzerland, as well as Zurich, and met everyone on the board and had some great times there. And I was really, really looking forward to attending this year. And I guess it just didn't work out for whatever reason. This is where I work in Birmingham, Alabama. This is our facility in the lower left. I also have a joint position at the biomechanics lab as well. I also have a national position in research and clinical education with Select Medical. And I also have a adjunct clinical professor position at Marquette University. So why cover advanced rehabilitation topics? Well, one is patients and athletes require higher level of functions today for work and sports and recreation. Also, in my mind, there's a greater focus on more than just strengthening, but mobility, dynamic stabilization, proper movement, pain-free function, neuromuscular control, and the ability to do this over a period of time, so endurance as well. What I'm going to discuss are aspects of advanced strengthening, such as rotator cuff and scapula, but also the integration of the lower extremity with the upper extremity with these exercises. Also, we'll talk about dynamic stabilization exercises. And maybe the most important aspect is the neurocognitive training and testing that I'd like to talk about quite a bit. We're all familiar with the phases of rehabilitation. We'd love to see patients preoperatively and See them all the way through to their return to competition. These phases overlap. So it's not just one phase and then the next phase starts and the next phase, but it's this constant integration of these phases. And we're always looking at criteria to progress from one phase to the other. Exercise selection is really important. Sometimes the exercise selection is good, but maybe the technique is bad, as you see here. Rehab is changing. Rehab is changing in 2022, but it'll be different in 23 and 24, 25 as well. My practice has changed dramatically where we affect the brain more than ever before and the central nervous system. Patients want to get better fast, but the reality is it can be a process, and depending on their involvement, it can take some time. My philosophy of shoulder rehab is really quite simple. End range stabilization, dynamic stabilization, good proprioception and body control and posture. There's more to shoulder rehab than the shoulder. So for me, it's posterior chain, it's hip, it's core. The cognitive aspect is really important, knowing how you're moving and also being able to affect that, neurocognitive in particular. And at the Swiss meeting now, you have one of the experts in the world speaking on motor control, Dr. Lynn Snyder-Mackler, who's a good friend of mine and has taught me a great deal about motor control, dynamic stabilization, perturbation, and all those things have integrated into my rehab program today. I might say also that proper exercise selection and ordering your exercises or sequencing your exercises are also very, very important. Here's a couple elementary exercises that I'll show initially. This is just giving some manual resistance with a resistance band. The arm is down at 0 degrees with a towel roll, and I'm doing some rhythmic stabilization at end range. Down here at 0, or close to the body, 0 degrees of abduction, the shoulder's in a very stable position. Here we're in the sideline position, very, very good for EMG activity of the posterior cuff. Towel roll is again applied, and I'm giving some manual resistance, and I can do rhythmic stabilizations as well. We did a study a few years back, published in 2004 in the Journal of Orthopedic and Sports Physical Therapy, looking at 7 different exercises to look at the EMG activity of the posterior cuff. And what we basically found was that side lying produced the greatest EMG activity of the posterior cuff, followed by standing, externally rotating at 90 degrees, followed by prone row into external rotation, as you see here, followed by external rotation in the scaption position at 45 degrees of abduction. And coming in last place was actually the standing position with your arm down at 0. We did find in that study, which was interesting back in 2004, is that using a towel roll increased our EMG activity about 20% roughly. It was 18 to 20% to be precise. It was 19.4 or something like that as far as the percent increase. And that was very, very consistent among all subjects. So obviously we like evidence-based medicine. It makes me feel good. It makes me want to jump. I get very excited when there's evidence and so forth. Side planking, trying to bring the legs, the hips into the equation. Instead of just laying on your side, we have you plank up. That way you're bringing in the hips, which are critical to shoulder function when hitting a tennis serve or throwing a baseball or throwing a softball or even some aspects of volleyball as well. And here I'm giving some manual resistance with an end range rhythmic stabilization again. Towel roll would be a good idea in this scenario. For some reason, I didn't use it. And obviously, surgical tubing can be used as well. And I can give manual resistance with the tubing as well with an end range rhythmic stabilization. So we just gradually increase the challenges of the shoulder. And then if it's an overhead athlete who has to go up into that position, we'll also do some rhythmic stabilizations at end range in that 90-90 position, as you see here in this thrower. These are some end range stabs where the person does the exercise. They're in this position. We have them up in that 90-90 position. And at a predetermined number of reps, I'll ask him to hold it and stabilize. That's a 2-pound plyometric ball that person is throwing up against the wall. I love this exercise for throwers, tennis players, volleyball players alike. Here we have the person seated on a stability ball. We have him extend his leg up. That way it produces core activity. So his core, his hips are all engaged. The reason I have him hold a dumbbell in his opposite side is a sustained hold that helps him activate shoulder and postural muscles of the scapula, but it's also endurance. It also increases the EMG activity on the opposite side by about 3 to 5%. This one, the person is doing the ball throws up against the wall, and I'm asking him as he throws to count backwards from 100 by sevens. So one more time, he throws this ball up against the wall. I tell him when to hold at end range, but he counts down from 100 by sevens until we tell him to stop. So again, this is dual tasking. There's cognitive aspect to this. It's a neuromuscular exercise for his shoulder, but it's also a cognitive exercise as well. Here's an example of a high plank going in the prone full can position. Here I ask him to extend his leg up to bring in that posterior chain as well. Another example of a high plank with a prone row into external rotation. Tough exercise to do. We like this exercise a lot, though. Low trap and certainly the scapula muscles are really, really important. This is my go-to exercise, one of them for the low trap. The person seated on a stability ball, he externally rotates. As he externally rotates, he posteriorly tilts his scapula. He creates this retraction or bringing the medial borders together at the same time. And what I have is biofeedback applied to his upper trap and lower trap, and I'm looking at the ratio. So I want more lower trap muscle activity than upper trap. And this biofeedback apparatus we really like to use around the scapula quite a bit. Here's another one of my favorite low trap exercises. It's a modification of the robbery exercise. We just call it the low trap. Here he's prone, so he's bringing posterior chain as well. Tough exercise to do. All of our exercises are done bilaterally. So here's a person prone on a ball, overhead athlete. Legs are extended, posterior chains activated. He's going to get his 10 reps coming up into a horizontal abducted position. On the 10th rep, I'll ask him to hold one side, and he moves the opposite side. Again, this is an example of a sustained hold. Tough exercise to do, but the rewards are very, very gratifying. It helps improve endurance. It helps with posture. It helps with stabilization. And it's also very, very good from a strengthening standpoint. And we'll do the same for other movements, such as the full can. Here's an example of just seated on a ball. We want to make sure he has good posture. He's sitting upright. He comes up into that full can position. Again, normally in the clinic, we would do 10 repetitions, ask him to hold at the top, and then move the opposite side. So we like these exercises a real lot. Also, a lot of middle trapezius, rhomboids, really, really important from a shoulder stabilization standpoint. Recently, we developed what we call our Youth Throwers 10 program. It's an exercise program that targets the young thrower. We publish this in the International Journal of Sports PT. I think it's a very good program where we try to bring in exercise where the person's engaging their legs. So using like a lunge position to lunge into the activity. So hips, legs, quads, their shoulder, everything's engaged in this. Here's the low trap exercise as well. We also want to make sure that even in a young person like this, we want to make sure they have good thoracic mobility. So we're doing movements such as thread the needle. We certainly have our Throwers 10 program, our overhead exercise program for more the adults, meaning high school, collegiate, professional athletes. We even have a golfer's 10, we have a tennis 10, we have a volleyball 10. What about neurocognitive exercises? What is neurocognitive? Well, it's the ability to recognize, react, move effectively, efficiently, and skillfully. There's a performance element to it, and there's also a prevention of injury aspect to it. It's fine motor, it's skill, it's dual tasking, it's speed, it's coordination. There's a lot of elements that all are integrated in. This is some work done by Dr. Grooms out of Ohio University looking at brain scans of ACL patients, just simply doing a knee extension exercise and a very short arc of motion, like from about 30 degrees to 0. He had a group of subjects, all of which had ACL reconstructions, but one group had neuroplasticity, the other group did not exhibit neuroplasticity. And what you can see on these brain scans is a difference in these scans as far as the location of activity of the brain. The ones that did not have neuroplasticity, they have a very small area of brain activation, whereas the people who had neuroplasticity, they're in the red, and they're using various areas of their brain to integrate in. So they have a faulty reaction activity level. As you see here, it's a very elementary type of activity that he's asking him to do, that he's measuring from a brain standpoint. And Grooms has published several papers on this and talked about different rehab implications: dual tasking, blindfolded, eyes closed, strobe glasses. A lot of visual input helps override this neuroplasticity. And as I mentioned, I'm sure Dr. Snyder-Mackler will talk about this quite a bit as well, with some of her excellent motor control examples and tremendous amount of research that she did as well. So this gives you a little bit of an idea what I'm referring to. This is an ACL reconstructed person, soccer player, recreational. He's actually a physician. And we use these light stimulus. So he has to locate the blue light. I throw a ball to him, and he has to catch and tap it, the whole time moving effectively, safely as well. And these are usually 30-second bouts. His right side, by the way, is his ACL reconstructed side. Many times we'll do things such as this, like a soccer type drill. So the person locates the blue light, taps it, has to locate the soccer ball handle it, dribble it to the next target, tap it, and kick it back. Sometimes we'll even use 2 soccer balls with this going on. So again, she's got to locate the ball, she's got to move effectively, she's got to hit it the whole time, moving normally as best we can. Here's another ACL patient. All 3 of these, by the way, were right ACL, ironically. So what he's doing here is a foot fire type drill in ladders, and I'm calling out the direction forward and backwards. I'm also calling out the drill that he needs to do. He has to catch a ball, and he's also counting backwards from 100 by 7. So a lot of things going on all at the same time. Sometimes we'll do, like I mentioned before, 2 balls. So here's a person on a rocker board. We're doing a perturbation, and the stimulus is coming from the front, but also from the side. So he has to recognize with his peripheral vision the ball coming, while Darius, the other physical therapist, is tapping the platform from behind, as well as pushing him as well. And this is an example, again, of a perturbation exercise for the lower extremity. We do a lot of these types of things, quick board type movements, where the person has to move in a very coordinated fashion. These are usually 30-second, 40-second bouts, so it can be very, very taxing to the endurance as well. Or we use an avatar system. This is called the Trapezius system, where again we simulate a football field, but it can be soccer, it can be a volleyball, it can be whatever we want it to be. and he has to move and hit the target. He has to locate the target, hit the target, but move effectively without overshoot. The visual element is important. We've tried to take the visual elements out of it. It just didn't quite work effectively like you see here. You saw this one before, so let's get into the shoulder now. Obviously, we've got about 10 minutes left, so let me expand more on some of the things that we're doing with the shoulder. This is an example of an exercise where the person does the wall dribble, has to locate the blue light, tap the blue light as they continue the wall dribble. Really tough exercise to do, especially from an endurance standpoint. But we also want to make sure that when they're throwing, they have a good arm position. They're not dropping down. They're not leading with their elbow. They're not doing something peculiar with their arm as they're throwing. And what I mean by that is bringing their arm down or bringing their arm forward in this position, but they're in a nice stable position with their rotations. Also, we can add in the neurocognitive aspect of the light stimulus, but also the end range rhythmic stabilization. Many times clinicians will ask, well, how do you fix those blaze pods on that plastic wall? It just comes with a suction cup and it sticks quite nicely and very durable as well. We do a lot of closed chain exercises. Here's an example where the pods are 36 inches apart horizontally, 24 inches apart from anterior to posterior. And all he has to do is locate the blue, stabilize his shoulder on the left as he's doing this. And obviously you can set these up in a variety of ways, whatever you think is appropriate. Here's an example of a gymnast with a shoulder problem, a little bit of hypermobility, as well as micro instability. So we have her doing a step over as she locates the blue light target. The whole time we're looking at, does she stabilize well? Is her scapula in a good position? Her core, so forth. We may ask, especially with gymnasts, we may ask them to put their feet on an unstable surface like you see here with this Bosu ball. This is an example of a pretty tough exercise. He has to locate the light. So he's doing a ball drop. And as he drops the ball, he has a sustained hold on the opposite side. He has to hit the target. And for some reason, that video is not playing, so I apologize. We can also have the person moving. So here she's in a plank position on elbows and just moving laterally and tapping the light stimulus. All these exercises, I might add, are designed just to give you ideas. And what's nice about the light stimulus is, and the targets from a neurocognitive, proprioceptive standpoint, is it's open to your creativity. And there are a lot of these I have put on my Instagram just to share with you and other people. So I want to share a few more exercises with you with the last few minutes we have together. And again, I just want to share some ideas to help stimulate you into more ideas on what to do. So here we're using the blaze pods. We've put them on an apparatus called the vector. It's like a fence that we fixed these to, where he has to locate the blue and touch it. This is a collision athlete. He's a NFL football player. Now what I'm going to ask this basketball player to do is react to the blue light as well. In this situation, I'm sorry, I misspoke. He's not actually just responding to the blue, but also the red. So we're asking him to use his right hand to hit the red light, his left hand to hit the blue. So that's a higher level of dual tasking in our minds. What's nice about these apparatuses, we can just use it on our phone. It gives us reaction time from every target that's hit. So we can see patterns where the person starts to fatigue a bit, like you see here. It gives us a number of targets hit. It also tells us how many errors and so forth. So here, again, is a football player where we're throwing a hex stick to him. This 3-prong apparatus has 3 different colors on it. We'll call the color out. So he has to catch it. And then he has to locate the blue. So he's got multiple stimuluses going on. So this can be fun. Obviously, we can make it as challenging or as simple as possible. We can put them up on the wall. We can make them throwing. We can make them stabilizing. We can do a variety of things. And obviously, there's other modalities or apparatuses available. This is the quick board that you saw for the lower extremity. We just lowered the tripod. So now it's for this gymnast for her upper extremity, where she has to hit the targets as well. And again, number of targets are hit, a number of airs, reaction time, looking at posture, a lot of things we're looking at with these types of things. If you want maybe a lower level introduction to it where you're not really getting reaction times and things like that, you can just simply use tape on the ground as you see here. And what I'm doing is I'm calling out left or right where she has to tap as well. Another example of a side plank where she locates the target. Now, let me get into a couple things with testing in the last 5 minutes. So this is the closed kinetic chain upper extremity stability test developed by Dr. George Davies. The 2 lines are 36 inches apart. The person's in a high plank position. Very nice exercise and test to do. The problem is it's not very reactive. It's very predictable. It's staged. And so we would just count the number of taps. So what we started to do, instead of just hitting the line, he has to hit the target. So it's a little bit more difficult. And then what we said was, well, that was interesting, but let's do something where we have multiple lights. So now we have 3 different lights. We have distracting colors going on, but we also have the target color, which in this case is blue. And you can see he gets motivated. He tries to do a really good job. He's holding it. So this is the test that we like the best now. So let me pause it for a second and set this up. 4 blaze pods or 4 lights. They're 36 inches apart horizontally and 24 inches apart anterior to posterior, so front to back. Where the instruction is stay in a high plank, maintain that, but your right hand will hit the red and your left hand, your right hand will hit the red and your left hand will hit the blue. So now it might be a 15-second test. It may be a 30-second test, but this is tough. So he's got to really have motor control to stabilize, but he also has to have the ability to recognize and react and move effectively. And we like this particular test a lot. We're in the midst of testing high school baseball and college baseball and softball players. Soon we'll be testing professional football players as well, because we want to compare upper extremity versus lower extremity athletes to see the differences. I think, endurance is critical for the shoulder. The ball drop exercise is one that I use in the clinic on a regular basis. It's relatively simple. All I'm asking the person to do is drop and catch that 2-pound ball while maintaining good body position on the stability ball. At a predetermined number, I'll say hold it, and he has to hold in that position. We use force plates as well, lower extremity as well as upper extremity. Here what we're doing here is a drop step, if you will, onto the hands. And what do we look at? Weight distribution, one side to the other. We look at how much force they're generating. But we can also have even push-offs off of the force plates as well. So we look at the ability to, when they step off of it, or I shouldn't say step, but press off it with their hands, how are they moving? And you can see there is some difference between one side and the other in this particular individual. So we're using a lot of different components, if you will, but we base it on what type of athlete, what type of patient we're dealing with. If they're a wrestler, if they're a gymnast, if they're a football player, we may use force plates in this position. If they're a throwing athlete or volleyball athlete where they're up in this position, probably nothing like that. It's strictly the throws into the wall and so forth. We obviously use a lot of plyometrics. We do a lot of these types of throws into a rebounder. We think that's really important from a functional progression standpoint. This is a two-hand overhead soccer throw, which we use a real lot. A lot of trunk movements, bringing in hips and core of the body into the equation. A drill like this, a precursor to throwing, it really can get these people excited and get them going into a sports type of environment. Obviously, the selection of the exercise is critical, that you do the right exercise at the right time and you don't do something totally inappropriate as this gentleman did, unfortunately. Not quite sure what he was trying to accomplish, but
Hi, Kevin. Many thanks. How are you?
Hey, Mario, how are you today?
Very good. So it's quite early there. Huh?
A little bit, not too early.
Still already had some breakfast or no?
No breakfast yet.
No breakfast. Okay, I think I'm sure that our people here and all attendees enjoyed your talk. Very excellent as usual. Lots of practicals. So, and I will pass the word to Suzanne, who is coordinating the Slido, and then we may also have some other questions.
Yeah. Est-ce qu'il y a quelqu'un qui veut poser une question? Oui? Ok.
Beh, cercherò di tradurlo. I don't know, Kevin, do you understand Italian or I translate?
Ciao.
I'll translate.
Translate, please. I'm sorry.
Se ci sono dei test oggettivabili, un dinamometro, in modo da poter fare dei return to sport misurati.
Yes. So do you also, the colleague is asking if, are you also using, let's say, handheld type of measures to objectify strengths as an example, and using those data also in your return to play package testing?
Yes, I think that's a great question. I use handheld dynamometry. I have for a great number of years. I think it's very important to objectively measure strength, particularly of the upper extremity. I tend to use more isokinetics for the lower extremity. For the upper extremity, I use the handheld dynamometer to measure ER-IR ratios, also deltoid ER ratios, and of course use it around the scapula. My preference is I like to look at bilateral comparisons a little bit, but I'm really like to look at unilateral muscle ratios, agonist, antagonist. And the reason I think that's important is because I'm always thinking about with the shoulder balance. And what I mean by balance is forces that have a certain percentage, if you will, to provide not only at the glenohumeral joint dynamic stabilization, but the proper synchronicity of muscle firing when you consider the scapula moving. So again, I think side to side is good, and I think it's important to look at. But in my hands, the unilateral ratios are more important.
Okay, thank you. I have a question from the audience via Slido. Is including the neurocognitive training superior to regular progressive loading, in your opinion?
I do a combination. So for instance, I think we're a little better, although we're getting to the point where we're happy with it. But I think we're a little better with the lower extremity as far as that balance between progressive loading and a strengthening program with agility and neurocognitive and proprioception. And I think, some of that is because of all the excellent work has been done by actually the people who are at your conference. Dr. Snyder-Mackler and Mario has certainly done a lot of work with soccer players, and Paul Glasgow and so forth. All those individuals have kind of taught us how to package the rehabilitation program and use different components. At the shoulder, and I think I know the literature pretty well. I think we haven't really done a great job from the proprioceptive neurocognitive standpoint. And so we're kind of learning now how to package that together. So for me, as far as a rehab program to give you percentages, I do, some range of motion, some strength, some stretching, some dynamic stabilization manually. Then we do our strengthening. And then toward the end of the program, maybe the last 20-25%, maybe a little bit less, is the neurocognitive. And I always do that toward the end when muscle fatigue is in play. I think that's important from an endurance standpoint. I think that's also important from an aspect of changing what is giving the body the proprioceptive information. So I hope that made sense.
Yeah, thank you. It totally made sense. Do you have other questions in the audience? No? Nobody? So when do you do the testing? Do you care about the scapular position or not?
Yeah, I do. That's a great question, a great point. I do care, and you probably saw in the video when we do the push-up position or the high plank, many times the scapula, medial border is coming off as they go into this retracted, protracted position. And I care about it. I just don't know what to do about it. And what I mean by that is I want them to focus on the task, and I don't want to, give them instructions and say, no, reposition your scapula. So I want to see them move in a natural state. And also my mindset in rehab, and I love to hear everyone's opinion on the panel as well. My mindset in rehab now has changed so much in the last couple of years with the advent of this neurocognitive kind of format with the lights in particular. And I'm so interested in reaction, how you move in quick, kind of chaotic situations. Because again, if we can go back to maybe lower extremity, if we think about a soccer player or we think about other sports, there's so many things going on at the same time that it's really important to put that athlete, that patient in the environment that they're going back to the sport. And I know in my hands, I wasn't able to do that in rehab before. I would do a hop test or I would do a shuttle run and I would think, oh, you look really great. Isokinetics look really great. And I think all that is important, but I really wasn't testing in that unanticipated, chaotic, dual tasking arena that athlete was going back to. And in my mind, I think that is really the reason why we have so many re-injuries is sometimes we return these people and I don't think we've really cleared them in the same type of activities or same type of environment that they're going back to. They go back too early.
Agreed.
So, Kevin, we could go on, but we have to continue the program here. So the best way you could is jump on a flight come for the after party. But
I wish I could. I just need that little piece of paper.
Okay.
It's been a little bit of a mess, and again, I know I apologized in the video clip, but I'm so sorry I'm not there at your Congress. I've been there several times before. It's a fantastic meeting. You do a fantastic job. Your Congress. It's a wonderful meeting with wonderful people, and I can only wish one day before I decide to retire, I can make it again. But I wish everyone a great Congress and congratulations on such a great success.
Many thanks. Thanks a lot that you took the time. Ciao.
Ciao. Thank you, everyone.